Good afternoon, everyone. Dr. Randall Wolf here, coming to you live from Houston, Texas, Texas Medical Center, the largest medical center in the world, and specifically Methodist Hospital. The topic is atrial fibrillation. It's a topic that concerns a lot of people in this world today. There are millions of people that suffer from AFib, and there are also probably millions that aren't very happy with the treatment of AFib. The purpose of this webcast is to introduce people that suffer from AFib with all the options that are available to help you. And what is the goal at the end of the day? The goal at the end of the day is to help patients with AFib so that when they wake up in the morning, they don't spend the whole day worrying about their arrhythmia. They go out and live their lives. Get off medicines, eliminate strokes, and live AFib free. That's the goal. And the first way to achieve that is to be informed on what the options are for treatment of atrial fibrillation. This webcast is a function of DeBakey, Heart and Vascular Center. Dr. Lumsden, our fearless leader, started these webcasts some years ago. They've been quite successful. We have a pretty large following of people that have had AFib and don't have it anymore for reasons we'll explain, and for new patients who are looking for all the options for treatment of AFib. While we are doing this webcast, and if you have a question, go to your phone, go to 37607 on text. Go to text 37607, type in DeBakey, and it's on the screen there, and text in your message. We will take your question live. Either me, or either I, or my guest will try to answer your question. If you're on your computer, go to pollev.com, enter DeBakey, and respond to the activity. Please don't wait till the end of the hour to ask your question. We'd rather the questions come up while we're talking during the dialogue, and we'll interrupt the dialogue to answer the questions. From time to time, or on the bottom of the screen, you'll see the ways that you can enter the conversation. So really, it's kind of a free consult. I have a special guest today. He is both a physician and an attorney. So he's a learned man, and he sees medicine from both sides. From the side as a physician who practiced, and as a practicing attorney in healthcare. And he's been very kind enough to take some time out of his busy day, come on the show, discuss AFib and also his personal journey with AFib, because many times when you hear someone's personal journey, you can relate, you can understand, and will give you ideas of how to pursue treatments for atrial fibrillation. Joe, thanks for coming on. Hopefully, can you hear us now? That's good.
You're welcome.
And I see you on the screen there. I'd like you to introduce yourself, because I think you can do it better than me. You're a very learned man. You got a lot of degrees, and you've got a lot of experience. Experience leads to knowledge, and knowledge leads to wisdom. I often say, look at the internet. There's a lot of information there, but it's hard to tell where the knowledge is. You got to ferret that out yourself, and it's even harder to tell where the wisdom is on the internet. It's there, but you have to figure that out for yourself. And you've been on both sides of this business with AFib, and you're a physician and attorney, so please introduce yourself, and if you don't mind telling us some of your story.
Okay, I'm happy to be here. I'll do anything for you after what you've done for me.
Thank you.
I'm 66 years old. I've been a licensed medical doctor for over 40 years. I practiced clinical medicine for about 25 years. I've actually have a unique law practice. I've been investigating healthcare industry for about 30 years. So there was an overlap between my medical practice and the investigations. I specialize in doing large international companies, mostly drug industry, medical device industry, and the military industry. And I'm out there on the internet. People can find out all about me. But it's certainly opened my eyes to a lot of business. I see medicine as a profession, like we all do. I love it as a profession. I think it's a noble profession, but I also see what it's sort of become and the business of it. And it's making decisions today is a little harder than it was years ago. You have to ask a lot more questions. You have to know the right questions to ask. And that's sort of that's the mindset that I come to this with. All right. So I've got 30 years experience investigating healthcare, 41 years as a physician. I'm a licensed doctor and I'm a licensed lawyer. Obviously, I don't have much of a clinical practice anymore. When I did, I practiced physical medicine. So I would treat knee injuries and physical injuries with people and do all kinds of injections and testing and things like that. But I really love the work that I do now. It's a high pressure job, as you can imagine. My medical issues, and I've had a bunch, just like anybody else, but AFib. This is all about AFib, so let's talk about AFib. I had my first diagnosis of AFib at Georgetown Medical Center where I went to school, and I was freshman. I was 22 years old, 23 years old. And I had this feeling in my chest, and I didn't know what it was. It felt like literally my heart flipping around in my chest. I went to the emergency room, and because I was a medical student, everything was free back then, Doc. You remember those days where you got treated to everything. They told me I had AFib. They told me it wasn't much of a problem, and it wasn't. Quite frankly, it would happen once a year for the next 25, 30 years, and it never became a real issue in my life. Fast forward, I started getting serious AFib attacks probably 2016, 17, in that area. I did not need to be cardioverted at that point because it would come and go, and I never really paid a lot of attention to it. And then finally, somewhere in the middle of 2019, I crashed. I was cardioverted in December of 2019, I believe at Mount Sinai. Lost my blood pressure, so I went into AFib, dropped my pressures down to like 70/50, maybe a little lower. Clinically, I was sick. I was passing out. I was losing my consciousness. Got cardioverted for the first time. Got cardioverted again about a year later, a little more than a year later. Again at Mount Sinai, May 2021. And that's when it sort of started. I was put on a drug called Eliquis to prevent blood clots that happen when people get AFib. I may have been taking an AFib medicine at that point. My primary residence is in San Juan, Puerto Rico, and I have another house in New Jersey where I come from. But I was in San Juan, started to bleed, had a GI bleed. And I recognized it, and I said, let me get back to New York. So I got on a plane. I didn't make it. I was taken off the plane by an ambulance. I ended up at Columbia Presbyterian with a hemoglobin of 6. And for the lay people in the audience, the average human being, male, let's say, has a hemoglobin of 14. It's a blood count. So I had lost more than half the blood in my body. And it turns out that it was the Eliquis that made me bleed. And I ended up with 12 blood transfusions, which is more blood than a human being has in their body. And they took a very long time, number of procedures before they even found where the bleeding was. And it turns out that the bleeding was coming from a 30-year-old surgical site. So I had surgery 30 years ago, which was fine. But this drug, which is to prevent you from having blood clots, opened up this surgical site from 30 something years ago and almost bled to death. And it was a bad time, just a bad time. So I had all kinds of procedures to go in and find that bleed, fix it. Then I got iron treatments and blood transfusions. As a result, I started to get, then about December 1st of 2021, I had another cardiac stent put in. All of this had brought out chest pain. And then I had a cardiac stent placed at Columbia. And at the same time, they said to me, well, you're having all this bleeding. You obviously don't do well with the medicine. Let's put a device called a Watchman. You see it advertised on TV. And what a Watchman is, it's simple. It's a little cage, kind of like a bag. And they tie it inside this atrial appendage. The doc will explain that more. And it's to prevent these blood clots from traveling around your body, from even forming. I didn't realize at the time that had I gone to see Dr. Wolf, I would not have needed that procedure. So now, what do? I'm sitting in the hospital, and they come to me and they say, "You've got to stop the AFib. What do you want to do?" And these conversions, I ended up getting cardioverted in 2000. That was 12/1/21. Then I ended up getting more AFib. And in January of 22, just a few weeks later, twice in 1 week, I was cardioverted. And cardioversions, depending on who's doing them, can be a pleasant, decent experience. Pleasant is a strange word to use for cardioversion. But at this point, I knew everybody. I mean, I literally was like old home week every time I go in. But they ended up using an anesthetic on me for one of them called ketamine. You know, if they give you propofol, which is a particular anesthetic, it's like the Michael Jackson drug, right? This is what Michael Jackson died from, I think. And you wake up, you're happy, you love everybody, you love all the doctors in the room, and your cardioversion's over, you're back in sinus rhythm, everything's fine. The next time, a few days later, I had it done through their emergency room. They gave me ketamine. Ketamine is an old horse tranquilizer, which was developed, I think, in the 70s for horses, and now it's back in vogue. And they use it in emergency rooms in AFib because it doesn't drop your blood pressure. But let me tell you, I had a terrible experience on it. I would never allow anybody to put that drug in my body again. And it was a horrific, traumatic experience for myself and my wife. I thought I died. All I saw was a white light. I went to a psychotic episode from it. And then I finally came out of it, but it was a dramatic, traumatic experience. So now I'm saying these docs, this can't be my life for the rest of my life. I can't function. And they said, no, we're going to do, next step for you is an ablation. I said, okay, what's an ablation? You know, even though I'm a doc, I know what the term means, but I don't understand what it meant for me. And it's a semi-invasive procedure, not non-invasive. They say semi-invasive. And I'll let Dr. Wolf explain it. But they kind of snake this tube up inside your body to get to the inside of your heart, because apparently on the outside of your heart, there are these errant waveforms that are causing the AFib. So your heart's supposed to behave in an electrical manner. In other words, the electricity passes through your heart. That's the normal little line you see on the EKG, you know, that little bump, that little QRS thing. But that gets all out of whack in AFib. It's because you've got these different little focal spots on the outside of your heart that are just firing. So your heart doesn't know what to do, so it sort of goes into panic mode, and it just fibrillates, it just shakes. The top half of your heart, the atrium, just shakes. And clinically, you're passing out, you feel like you're going to die. So these fellas go on the inside of your heart and then try to burn holes to the outside, burn this from the inside of the heart to get the spot on the outside of the heart. Now, they don't go on the outside of the heart because to get to the outside of the heart, what do you have to do? You have to go through the chest wall. They go inside the heart. And the way I explain it to my family, who are not doctors, I say, look, every morning, my wife and I listen to this woodpecker, true story, woodpecker banging on the outside of our house, right at the bedroom. just banging on this. Have you ever heard of woodpecker? It's like the most annoying thing in the world. So this woodpecker's banging on the house, and you just want to make this thing stop because it's like 6 o'clock in the morning. He's banging on your house. So imagine if you want to get rid of the woodpecker. So you pick up a gun and you start shooting at the woodpecker through the wall of your house. You don't know where the woodpecker is exactly. And every time you shoot, he moves. But you're shooting this woodpecker and you end up with all these holes in your house. And guess what? You don't get the woodpecker. Well, in this case, those errant waveforms are like the woodpecker, but they're not on the inside. You're on the inside of the heart shooting out. You really need to go on the outside of the heart. So I'm back in New York and these people are explaining this procedure to me. And I'm like, this sounds archaic. I said, does it work? And they said, well, 35% of the time, 40% of the time. I said, how many hours of general anesthesia is that? They said 5. I said, so you're telling me you have to go in, put me under for 5 hours, and then I have got a 30% chance that this procedure will work? And then what if it doesn't work? They said, we'll do it again. I said, well, at 30%, that means the average patient's having this thing 3.5 times at 5 hours. At each time, 5 hours of general anesthesia. That's like 20 hours of general anesthesia. That doesn't make sense to me. And then I asked them, I said, who does the anesthesia? I said, we do, and I'm not going to name the institution. They said, we do 3 tables at a time. I said, you have 3 tables running at the same time. How many anesthesiologists, MD anesthesiologists do you have? They said, we have 1. I said, well, who's sitting at the head of the table? They said, a nurse anesthetist. And then I said to the doc, young guy, nice person, and I just said, what happens if there's 3 tables going at once? There's 1 MD anesthesiologist, and 2 of those 3 patients have problems at the same time. Which one does this MD go to? And he looked at me. And I said, if you don't have an answer to that question, you shouldn't be doing that. And I don't think this is the place for me. So I decided to go on the internet and start searching around. I said, let me start with Houston, because my wife survived metastatic melanoma. I had taken her to Sloan Kettering, but the care wasn't just there. There's a lot of bells and whistles that were going off. So I end up calling a college friend of mine who had ended up becoming the CEO of MD Anderson in Houston. We took my wife there, and they cured her. I mean, they used immunotherapy, and God bless, she is now 1.5 years clean. She had metastatic disease, that's all gone. So I said, let me just Google atrial fib doctors in Houston. And I find this guy, Dr. Wolf, which is, by the way, my wife's maiden name. And I'm looking online, and I'm looking at one of these seminars, I guess, that we're doing now. And being a doc, I actually look at the procedure. He's got videos of him doing this procedure. And what he does is totally different. He goes outside the house and shoots the woodpecker. He goes out, he looks at where the woodpecker is, he aims at it, and he shoots it, and he kills it. In terms of a heart, he goes not through the inside of the heart, because the nerves that cause all this problem are on the outside of the heart. So he goes to the outside of the heart. But in order to go to the outside of a patient's heart, you've got to go through the chest wall, right? So you can't get to the heart by going through an artery or a vein to get to the outside of the heart. You have to go through their chest wall. Well, in order to do that, you need to be a cardiac surgeon. To do the other procedure, you just need to be an interventional cardiologist. Big difference. So if you're a hospital and you want to do what Dr. Wolf does, you've got to go hire yourself a cardiovascular or cardiac surgeon, somebody that can go through the chest wall. If you just want to crank out these ablations, these non-invasive ablations, you can use an interventional cardiologist, which is a cardiologist, not a surgeon, with some extra training to go in and snake around inside your heart until they find something. Well, when I said to Dr. Wolf, and I looked at his statistics, and I don't want to quote his statistics, he's capable of doing that, but he's done thousands of these patients, and they have tremendous success. And the cut to close time, which is a doctor term, the amount of time I spent on the general anesthesia was less than 3 hours. One and done. And I noticed, I was going to say something to you, Doc. The title of the title of the webinar here, you said, a physician lawyer with AFib. That's a mistake. It should be a physician lawyer who no longer has AFib, who used to have AFib, who had AFib, but doesn't have it anymore. I have an indwelling monitor, this little silver bullet kind of gadget under the skin of my chest. It's like an ongoing 24/7 EKG. And since I got off the table, the operating table, which was March 23rd of this year, so that's 8.5, 9 months ago almost, I haven't had one fibrillation, not one. Now, what I have had is I've had instances where my heart rate, which is normally 88 to 90 in that range, my heart rate has gone up as high as 120 something, because I've had COVID twice since then. And every time I had COVID, my heart races. Now, before the surgery with Dr. Wolf, if my heart rate hit 110, I went right into AFib. I mean, you could just get me to the hospital because I'm in AFib at that point. I've been over 110 for various reasons, 6, 8 times, 9 times since the surgery, and not once did I go into one fibrillation, not once. Okay. And so, I said, this is a miracle. The shame of it is that no one at the major university hospital in New York, where I was being treated, even mentioned the existence of this procedure. And that was like really disheartening. They know about it. They certainly know about it. They just don't do it. You have to ask them why they don't do it. What I asked Dr. Wolf was, am I going to have an MD anesthesiologist at the head of my table? And he said, yes. And I said, how long am I going to be under anesthesia? And he said, a couple of hours. And then you'll be in the hospital for a few days, and everybody's different, And there was some recovery involved. Anytime someone goes through your chest wall, you end up with chest tubes, and those have to drain for a day or two. But it was great. And honestly, if you have to get sick and get treated anywhere in the United States, Houston's the place. It's night and day. I mean, the hospital is like a 4-star hotel or a 5-star hotel, and the food was great. And the quality of care, not just the doc. The doc is one piece of a big team, right? You could have the greatest doc in the world, but if the person drawing your blood doesn't know what the heck you're doing, it's a nightmare experience. True story. I was in New York during one of these inpatient stays. A woman comes in, I'm there because I'm bleeding to death. I'm there because I literally almost bled to death, and I'm being transfused. She comes in to draw my blood. She pulls out 21 tubes of blood that she wants to fill. 21 tubes. She got a little machine. The machine is spitting out these little pieces of paper. The machine is printing the labels for the blood. Yep. The machine prints out 21 labels. So she pulled out 21 vials of blood, 3 of everything. And I look at her and I just say, listen, I'm here for bleeding to death. Why are we drawing all this blood? And she says, I don't know. She didn't speak English. That's the truth. And nothing against people who don't speak English. My grandmother didn't speak any English. But she drew 21 vials of blood. And I said, get me a supervisor. I'm not doing this. And let me tell you something. No thank you is the most important thing you can learn whenever you're in a hospital. Okay? No thank you. So I said, no thank you. And get me somebody who can explain to me why you're drawing 21 bottles of blood. So she gets a supervisor, and I said, why 21 vials of blood? I'm bleeding to death, and there's a bag of blood hanging up here. So you're taking 21, 6 or 7 cc's each. You're taking 120 cc's of blood. She said, the machine made a mistake. It printed everything out 3 times. And I'm like, really? So did you draw? And then the next question, because I'm I'm a lawyer, right? So I said, did you do this to everybody in the hospital? Like, is everybody getting 3 times as many blood drawn because the machine's making a mistake? And she just gave me that dumb look, And I said, can we fix this and maybe draw 7 vials of blood and get rid of the other 14? And she said, absolutely, doctor. And I said, thank you. So that's what goes on. And you have to be a very strong advocate for yourself. But here's the problem. You don't know how to advocate for yourself because you don't know what I know. And I don't mean that in a bad way. It's just that I've spent 30 years investigating healthcare. I've spent 40 years as a doctor. I'm a licensed lawyer, licensed doc. What I went through was crazy. There should be a Dr. Wolf in every major institution in America. There should be one at NYU. There should be one at Columbia Presbyterian. There should be one at the Mayo Clinic. There should be one, and I don't know that there is, but I know there's not a lot in New York because I've called all those facilities and they didn't do this procedure. I went to Houston and I'm really glad I did. When I met him, we hit it off. He's what we call in our profession a doctor's doctor. What does that mean? I try to find doctors. And a doctor's doctor is a doctor that other doctors would send their family to. Okay? And that's very important. The trick today in getting decent health care is finding a doctor who how do I say this nicely? Finding a doctor who gives a hoot. Okay? Finding a doc who's engaged in you, who actually is paying attention. Because all of them sort of know what needs to be done. The trouble is, do they really stop and take the time to focus on you, listen to what you have to say, and then do the right thing for you? Not necessarily what the administrator of the hospital is telling them to do that makes money. And I hate to sound coarse like that, but there's a lot of this involved. A lot of these decisions at the major hospitals. There was a case in New York, a malpractice case that just settled. And it was a young Spanish man went in for knee surgery, and he ended up getting treated by some company called Anesthesia.Inc., which was just a corporation. And it was one of these deals where they were running 3 or 4 tables at the same time, and they screwed up his anesthesia, and then he became crippled, for lack of a better term, for the rest of his life, and got a $21 million judgment. And the judge was so angry, he said, next time, maybe Anesthesia Incorporated will pay more attention to the people on the table, meaning the patients. And that's a small part of it. So you always have to ask, research, the doctors where you are, particularly if you're at a university hospital, you think you have a better chance of getting great advice. I was at a university hospital. I was at Columbia University Hospital, and it just wasn't great advice. And they didn't even tell me that the mini maze existed. Did not tell me. Didn't mention it. Okay. And actually, when I said I want to go get it, one of the docs there actually talked against it. But I made my own decision, and I'm so glad I did because I'm one and done. I'm treated. I'm never going to have AFib again. I feel that 100%, and I really feel like I made the right decision.
Joe, that was. Can you hear me? Can you hear me? That was an excellent summary. You're a very good speaker, and you've thought about this a lot. Dr. Piacentelli, am I saying your last name correctly?
No, but that's okay.
Oh. Well, how should it be pronounced?
Piacentile. Piacentile. It's Italian. You'll get it.
Do I have to have a cigarette in my mouth to say that right?
It helps. It helps. A glass of wine.
And I need to make some hand motions too, right?
Piacentile. That's it. That's the way to do it. You got it.
Well, you bring up a lot of important points, but first, and we have several questions, and by the way, we have room for more questions, so if you're listening and you'd like to ask a question, please go to the prompts that are at the top of the screen or at the bottom of the screen, whatever you're seeing, and get on your phone, 37607, text DeBakey, or on your computer, you can see on the screen how to get to us and ask your question, because you've got some people here that have some knowledge in AFib. We're happy to help you out. First of all, in summary, you had a complication from a blood thinner taken for AFib. that put you in a precarious situation. And by the way, you weren't in the United States when it happened.
Correct.
And you were going in, you had a lot of AFib, so your AFib burden increased to where you were out of rhythm more than you were in rhythm. Is that correct?
Correct.
So you've got a situation, a complication from the blood thinner. Of course, the main concern of AFib is having a stroke. You can't take the blood thinner. And you're looking at, they recommended a Watchman, right? And
yes,
did you have, you had the Watchman, did you have any ablations before you came to Houston?
No,
okay.
I didn't want to go down that path.
Right. So, a couple points there. The Watchman device is becoming quite popular amongst the electrophysiologists, and now they're putting them in earlier and earlier in the course of disease. I saw 2 people this last week who had Watchmans in, hadn't had an ablation yet. The Watchman device, the way I think about it, Joe, is like a plug. You're putting a plug, a cork. It's like putting a cork in a hole. And the newer Watchmans work better, but they're still recommending some anticoagulation after the procedure because the risk of stroke goes up right after the procedure instead of down. But the other important point is a Watchman device does not electrically isolate the appendage. And the appendage has electrical activity in it too. In the mini maze, we put a clip on the appendage which totally occludes it, and there's no need for any anticoagulation after the procedure, not even for 1 day. And maybe even more importantly, it's electrically isolated. In your case, I had to decide what to do, and what I did, as you may remember, I went around the base of the appendage, and I could see the little tines sticking out from the Watchman, and used a pen, a bipolar pen, to try to electrically isolate that appendage from the outside with the pen. Is that 100% satisfactorily? I don't know, but I had to think of something to do to try to electrically isolate the appendage. And the easy answer to a question is no. The question is, can you just put the clip on if there's a Watchman in place? No, you can't. It would not be safe to do. It wouldn't work very well. So once the Watchman is in, it precludes clamping the appendage, at least in my opinion. I don't think it would be safe to do. So
had I known now what I knew then, I never would have had the Watchman device. I would have said no. But since I didn't discover you until after that procedure, I regret having the Watchman. Because but for the Watchman, you would have been able to clamp off the appendage.
Right, that's correct. Now, you also brought up an important point, both on the physician side and maybe on the legal side too. Is it not important for physicians to explain to their patients what all their options are?
You know, it's a good argument. I would argue that how can I get informed consent for a procedure when I don't explain the alternatives to you, correct? Yeah. So if I'm saying to you, you've got this disease almost killed you, this disease brought you to the emergency room 4 times where you bottomed out your blood pressure, we want to put in a device, this Watchman, we want to ablate you, there's a 30 to 35% chance the ablation will be successful. You'll end up maybe needing it 2-3 times. That's fine. But then you don't take the next step and you don't say, by the way, if we put this Watchman in, it'll make it more difficult to get this mini maze. They don't even tell me the mini maze exists. So how can I have an informed consent to an ablation when I'm given no other option? Okay, I'm trying to think of an analogy in medicine where you could say, your kidneys are failing and you're going for dialysis, but you could get a kidney if your spouse donates a kidney. There's a program where if your spouse donates a kidney, you get a kidney because they donated a kidney. if I never explain this other option to you, which is a viable option, have I really explained everything when I went? So people who go for an ablation, who have no idea that there is a very real, viable alternative to that semi-invasive ablation, if I never explain the existence of that alternative, have I really gotten informed consent?
Right. That's the way an attorney would couch it. That's one of the major issues. Also, I think we've got a lot of questions here. So let me get into the questions in no particular order, because we should discuss some of this, and then we'll carry on with some other questions I have for you. And by the way, sitting next to me is my medical student, Akus. He is from Hungary, from Budapest, Semmelweis University, which in the medical profession is well known because they had some milestones there in the late 1800s. And he'll be Dr. McLaury after this year. He's here with me too, and he's been helping me with the AFib patients. In Japan, they removed, this is a question, Joe. In Japan, they removed the LAA, left atrial appendage. Why is that not done in the US? Well, initially the mini-maze was removing the appendage because I used a stapler, a lung stapler, that we used to close the appendage, and it stapled the appendage and also removed it, which is fine. When the clip became available, I was the first one to use it in the United States, and I worked on the development of that clip. And most of the instruments I use, I either developed myself or worked with engineers on development in the lab, which I continue to do today. We have about 7 projects today. When the clip became available, I started to use the clip. Why? It's a little bit faster, it's a little bit easier, and it's a tiny bit safer. So generally I'll go to the clip. The clip closes the appendage the same as the stapler, but it doesn't remove it. In Japan, at least until recently, the clip was not available. So the clip was not an option in Japan. Most of the surgeries are supervised or performed by Dr. Otsuka. Otsuka is a former fellow of mine. I'm the one who got him into the AFib business. He does a procedure called the WO, which is the Wolff-Otsuka procedure, the O standing for Dr. Otsuka. He does it a little bit differently. He's very good at it. He does a very nice procedure. But until recently, the clip was not available in Japan. Here's another question. I'm in line for a May surgery. I guess that's May 2023. If there's an earlier opening, is it possible to use the slot? The answer is yes, and we move people up. Did we move you up, Joe? I can't remember.
Oh, yeah, you moved me up.
What was the situation? I don't remember what.
Well, okay. I called your office. You didn't have an appointment you didn't have a slot for like 5 months. So,
oh yeah.
I don't want this
now it's coming back to me.
Yeah. Do you want me to tell the story?
Yeah, you can tell the story. It's funny.
All right.
That's not why you got moved up, but go ahead and tell the story.
All right. Well, I said to my secretary, I said, send him like $300 worth of Godiva chocolate and just say, it was great talking to you on the phone. So I sent you the Godiva chocolate, and then that was before I came to see you for the consultation. I'm sitting in the room with my wife, waiting for you. You walk in, and you look at me, and you say, "Are you the one who sent me the chocolate?" And I said, "Yes." And you said, "I've got a cancellation in 2 weeks. You want it?" I said, "Absolutely." And I got my procedure done a few weeks later.
Yeah, it wasn't because of the chocolate though. I was still concerned about you because how long had the Watchman been in? I don't remember, but I was concerned about you having another bleed.
Yeah, no, the Watchman had only been in. You did your procedure on me March 23rd, 22, and December 1st, 21 is when the Watchman went in.
Yeah.
So I was only 4 months with the Watchman. Plus I was 50 pounds heavier than I am now. And that's something I think I want to mention to people. You and I talked later. I think we went out to dinner, and I said, I got to tell you something. This is crazy, and you're going to think I'm nuts. But my appetite just died after the surgery. I mean, I dropped 50 pounds. And not because I was dieting or anything. I just did not feel as hungry afterwards. And it was directly related to the surgery. I was on no change of medications, no psychological issues, no reason to lose my appetite. And that's still the way. I'm still dropping about a pound a week. And I asked you about that. I said, have you ever heard that? And you told me you had an experience with a lot of people. You had, that you really weren't sure why that happened. And I just want to ask you, does that commonly happen? Do you get people with that story? Because it was dramatic.
Yes, yes, it does happen. And that's probably, there are probably several reasons. It's probably what we call multifactorial. One is, I think, when you finally realize that you're staying in rhythm, you feel a lot better. And it's kind of a come to Jesus moment if you're overweight and you say, I think maybe I can get in better shape because now I'm in rhythm. Another reason is if you're in rhythm, you have more energy and you're more likely to get a little more exercise. Now, exercise generally is not going to make you lose weight in and of itself, but it puts you in a different frame of mind. And the old saying, I eat because I'm depressed because I'm overweight. It's a circular thing, and you can kind of get off that merry-go-round once you say, hey, I feel better, I'm in rhythm, I'm not taking a blood thinner anymore, I'm not worried I'm going to bleed out if I go out of the country and can't get back in. So I think it's multifactorial, Joe.
In my case, it really wasn't any of those things, I don't think. Okay. Just for me, I'm speaking.
Yeah, that's all right.
I'm just speaking for me. I actually didn't have the appetite. And even my wife noticed it. My appetite just dropped. And I don't know why. And I have no reason to know why. But that was my situation. That's all.
Let's take a few more questions here. I wanted to mention one other thing, too. There's a big push saying, well, okay, maybe catheter ablation isn't as good as a mini maze, but at least you're not having surgery. Well, this is the way I look at it. Catheter ablation is much easier on your skin because it goes through the groin into a vein. But it's much harder on your heart because you're burning up the inside of your heart, and that's irreversible. You kill that muscle, it's gone for the rest of your life. The mini maze is more on your skin, more invasive on your skin, but it's much, much less invasive on your heart. We're not destroying heart tissue. We're not burning up the inside of the heart. We're targeting, as you said in the analogy, we're just killing the woodpecker and not putting holes all over your house. So it's less invasive on your heart, and in my mind, that's more important.
Well, also the anesthesia. If you look at the number of hours that a person is under anesthesia, if they have 3 ablations, it's up to 15 hours of anesthesia, as it was explained to me at that university hospital.
Well, Well, keep in mind, 3 ablations does not guarantee that then you'll be in rhythm either.
Right, but I'm just looking at hours on the table, okay? When I started in medicine, I started in general surgery, and we always were concerned about hours on the table, anesthesia time. And I just didn't see the logic of doing a procedure 3 and 4 times. If it doesn't work the first time, what makes you think it's going to work the second, third, or fourth time?
Exactly, yeah, that's right. That's right.
It just didn't make sense. It wasn't logical to me. Things have to make sense to me.
Yeah.
And when I went to you, I was on the table. I don't remember. Do you remember how long was I on the table? 2.5 hours, maybe?
Yeah, about that.
Right. And then at 2.5 hours, and then, there was a couple of post-op days, where you have chest tubes in. That's the nature of doing the surgery. Mm-hmm. But then I'm done. One and done. I had 1 procedure. I was in the hospital for a day or so, and then I went home, and I recovered at home. and I had some tightness of my chest because, you go through the chest wall and all that. But that's it. I never had AFib again. I never had to be cardioverted again. I didn't have to go back in and think about having another procedure and another procedure and another procedure. It was one and done from my perspective.
And no blood thinners.
Oh yeah, I'm on 2 or 3 meds. I'm on aspirin. I'm on a light dose of a beta blocker for my blood pressure, and I take a cholesterol med. That's it. That's all I'm on.
Yeah. Okay, here's some more questions. Do triggers of AFib exist after the mini-maze? After veins are isolated, do you still have AFib but just do not feel it? Well, no, and I get a lot of emails. People say, I did this, I did this, I did this. These were all triggers before my procedure. Now they're not. They're gone.
They're gone.
What do you say?
Yeah, there's no triggers. There were triggers before the procedure, but nothing since. Before the procedure, if I tried to sip a glass of wine, I would go into AFib. If I went into AFib and I went over 110, I would go to get cardioverted. I've had alcohol since then. I mean, I don't drink to any great degree, but I've had alcohol. I've had coffee. I have coffee every day now, a cup of coffee a day, maybe 2 cups on a crazy day. I have no triggers. I have a good relationship with my wife, you know what I mean? And all of those were triggers for the AFib before. But my life has been normal since.
Yeah, well, I got a story about that. Joe, I think your wife was coming to Houston for a follow-up. You came with her and said, hey, I'll take you out to dinner, Doc. My wife and I will take you out to dinner. So you came into town, and I met dutifully at the restaurant, and your wife wasn't there. And I said, where's your wife? And you said, oh, she scored a ticket to the playoff, and she's going to watch New York play Houston.
Houston and the Yankees. Yeah, she's a big Yankee.
Yeah, Houston. The Yankees. Okay.
Yankees lost.
What is Dr. Wolf's experience success rate for patients with postcapsular ablation flutter? Well, there are whole conferences on what's called left atrial flutter or atypical atrial flutter. That's where the top 2 chambers of the heart are beating, but they're beating faster than the lower 2 chambers. And patients tell me that's just as symptomatic as AFib. So this is a very common complication of a catheter ablation. It is not easy to treat, and initially I didn't know that a mini maze would treat it, but as it turns out, it does. And what we usually find is of the 4 veins, only 1 or 2 are really isolated, including a lady who came to me from Long Island a few months ago. It had 6 ablations. And we went in there, the veins were not isolated. So once you properly isolate the veins, you get rid of this left atrial flutter. We never saw atypical left atrial flutter before the ablations. That's what's really it's really an iatrogenic flutter, you know what I mean, Joe, but it's really caused by a procedure, by an intervention.
You should explain the word iatrogenic, because everybody in the audience doesn't know what that means.
You can explain it better than I can. I mean, it means it's caused by something
by the doctors.
Something that the physician does. It's sort of an unwanted complication for sure.
Doctors have a lot of buzzwords and a lot of little key words that we use that we don't want the patient to know, so that we can say things like, this is an iatrogenic problem, meaning somebody screwed up, or the patient's problem is supratentorial. Do you remember that one?
Yeah, I remember that one.
Which means it's above the tentorium of the brain, which means the patient's nuts. So we would pass these little comments to each other because the patient had no clue what that meant, but that's a way of us communicating with each other. So an iatrogenic problem just means, but for the fact you went to the hospital, you never would have the problem.
Right, exactly. Question, I watched several of your YouTube videos along with several YouTube videos of AFib along with yours. Some speakers talk about reversing AFib natural way by avoiding triggers and eating healthy diet. Can you reverse permanent AFib? Now that last sentence is the kicker, because I do think you can decrease AFib activity, episodes and length of episodes, with multiple interventions. Losing weight, taking care of sleep apnea are a couple of things that will help. Decreasing your stress level. Some people have claimed that yoga helps. I believe it's true. However, if you're in permanent AFib, if you're out of rhythm all the time, it's unlikely that all those will get you back in rhythm. If you have intermittent AFib or AFib a couple times a year, I think some of the interventions help. What say you?
I have a question. I think it's nonsense. No, I think you're right. But if you look at it from my point of view, I'm an alpha, and I live, I'm a lawyer and a doctor, and I run a practice, and I do investigations for a living. All I have to do is give up wine, give up coffee, stop having sex with my wife. Those are all triggers. Get rid of all the stress in my life, which means quit my career entirely. Stop talking to my family because they trigger me. That just, for me, it all sounds great and fluffy to do all those things, and I'm sure people can do it. I could never do that.
Yeah, that's a good point. Good point.
It wasn't working for me. Yeah. I have a question. Why is it that every time I went into AFib, I ended up in an emergency room with 5 guys putting paddles on my chest, right? And I've got a friend who's got AFib, and he's walking around talking, and he's in permanent AFib, and he looks fine, and he feels fine. If it happens to me, I end up with my life in my hands. So Can you explain to me how one human being can have AFib and be on death's doorstep, seeing white lights, right? And then the other friend has AFib, and he feels fine.
Okay, and this is a common question. It's a very good one. We did a study years ago when I was at University of Cincinnati. We put monitors on people with AFib, monitored them 24/7 for a week, and we asked them to keep a diary. When they were out of rhythm, write it down, and write down when they went back in rhythm. And we had all the information because we had their tracings. The patients were only right half the time. Now, in my own experience over the last 20 years, I have seen people, many of them, that know the exact time they go out of rhythm and the exact time they go in rhythm, and they are incapacitated by AFib.
That's me.
That's about 50% of the people. But the other 50% of the people go in to see a doctor for a colonoscopy, and they go, "How long you been out of fib?" And they go, "What are you talking about? I don't know what you're talking about." So it's kind of 50-50, and I think the answer is we're not all wired the same.
Okay.
We're not all wired the same. My resting heart rate's 43 to 46 on 100 of amiodarone. My cardiologist just reduced my dose to 50 to raise the rate. Will this be an issue for the mini-maze? Good question, and I'll tell you why. If you are out of rhythm continuously or a lot of the time, starting amiodarone preoperatively helps a lot. It kind of settles the heart down. We've had many patients who have been out of rhythm continuously. We start the amiodarone low dose, and that's the key point, low dose, so you avoid the side effects. And after a month or two, they go in rhythm. They have their mini-maze. Those patients do great. So the mini-maze is helped greatly by starting the amiodarone preoperatively and keeping it on for about at least 90 days post-op. It really smooths things out. Now, will raising the rate, will this be an issue? Not at all. So being on amiodarone pre-op is actually quite helpful and recommended if the heart's out of rhythm continuously before the operation. Getting ready for mitral valve repair, open heart at a location close to home. Can the mini-maze be done on outside of the heart at the same time? Yes, and it should be. And we see this, the last survey with heart surgeons suggested that only about 60% of the time when the patient has AFib and has an open heart procedure is the AFib addressed. And there are many reasons for that. A lot of times the surgeons will go, if you would have told me you had AFib, I would have fixed it. Well, why don't you ask me? So a lot of times the surgeons don't ask the question. Sometimes it's in the chart and they didn't see it. But it's important for you to say, I have a history of AFib, and when you're in there, can you do some form of the maze procedure? And if they say no, you're probably not in the right place. If they say yes, somehow try to make sure that this isn't their first rodeo and they know how to do the procedure. They should, but it's very important to get it done at the same time. And even more importantly, make damn sure they close the appendage while they're there, because it's difficult to go back and close it later after open heart surgery. Akos, you've been very patient. Do you have any burning questions, or do we cover them all?
Yes, I would like to have a question. How do mini-maze affect heart, blood pressure?
Oh yeah, that's a good one. Mini-maze and blood pressure. And this is based on some studies that were done. If you close the left atrial appendage, you decrease blood pressure. You decrease the renin aldosterone feedback. So this is an endocrine thing. There is some endocrine activity of the appendage, and by closing it, you decrease that and you decrease the blood pressure. We have many, many patients who are on multiple blood pressure medications before the mini-maze who've gotten off all their BP medications. Now, part of that's getting in rhythm, but part of it is closing the appendage. It's been looked at. You close the appendage, you decrease the renin output. It's a hormonal thing. Now, people say, well, is that bad? No, it's good. And you still have another appendage, so you still will have some of that hormonal output. Did you know that, Joe?
Yeah, actually, in my case, I was going to mention, in my case, I have what they call renal hypertension. I had chemotherapy years ago for cancer, and the chemo damaged my kidneys. So I've always had hypertension. Before my mini-maze, I was on 3.5 meds. I've reduced my blood pressure medication post mini-maze by 60, 70%. So I'm on about a third of the amount of medication that I was prior to the procedure. And it changed my life. I just got back. We went on a trip for almost 4 weeks, and I was walking and talking, and I wasn't short of breath. I wasn't worried about getting AFib, and my blood pressure. I manage my blood pressure now with one medication, Toprol, which is a beta blocker. You know what that is? It's an old-fashioned drug, and I manage quite well. I monitor my pressure 3-4 times a day because of its renal hypertension, not like regular high blood pressure. But the bottom line is, after the procedure, my hypertension improved and my ability to treat it improved.
And there may be another factor with respect to mini-maze, because we're changing the autonomic nervous input a little bit around the heart. I think that's part of it too, because some of this is regulated by the autonomic nervous system, and really we didn't talk about it much, but that's where I think the action is. That's why you got to be on the outside of the heart. It's any closing, I guess I should say, you'd be familiar with this, any closing comments? You have anything, because we've already, believe it or not, we've already taken up an hour.
No, I'm fine. Thank
you for the.
I do want to make one last comment. Houston Methodist Hospital is a phenomenal place to have your work done. I was a caregiver for my family for many years, for many members of my family. I've been in 50 hospitals. It's a phenomenal institution. The people, the facilities itself, just really top rate, and it makes the whole experience even better.
Thank you for those kind comments. If someone has questions for you specifically, is there, and we don't give out any numbers on this show, but is there an email they should reach you?
Yeah,
or?
sure. It's my last name at nih.gov. It's patients.It. P as in Peter, I-A, C as in Charles, E, N as in Nancy, T as in Thomas, I-L-E, patients.It at me.com. PIACENTILE at me.com.
Thanks for taking time out of your busy practice to help educate people.
I'd do anything for you, Doc.
What's that?
I would do anything for you.
Well,
change my life.
You're very kind. Ladies and gentlemen, we're going to close out this program. Thank you for listening. Thank you for your excellent questions. We will do this again in a month, first Tuesday of the month, as long as doesn't fall on a holiday. Normally 5 p.m. Central Time. We had to move it up because of conflict, but normally it's at 5 p.m. and we'll continue this conversation about atrial fibrillation. Thank you so much for helping us out this week, Joe. Appreciate it.
You're quite welcome. Thank you.
Thanks, everybody.
Okay.